Good day, people. We're continuing on with our series as far as patient positioning is concerned. So this is the second series, going a little bit more in depth into options available in each actual common patient position. So we've already spoken about seated. Today we're going to speak about lateral recumbent, lateral, side lying. There are different ways that people describe it, but basically the patient on their side. So just to kind of go back to our general concepts previously about patient positioning, as far as contact is concerned, when we're talking about the concept of the table makes stable. So as far as the table makes stable is concerned, they're in lateral. So the patient is in a position where they have essentially the second least amount of contact surface with the table, versus say prone or supine where they have the most, and more contact than in seated where they have less. And we've already discussed seated, and we've gone through that a little bit more in depth. As far as lateral is concerned, we also have to consider the second concept. When the table makes stable, so when there is less table, I need to make the patient more stable. Then we consider the third concept that we've spoken about previously, that the space between us is unstable, so I need to bring the patient into more contact with me to make up for the loss of stability from loss of contact with the table. Okay, so we're going to talk about those things. Now, as far as lateral is concerned, many motions are clearly available, and some people have preferences for lateral, but we want to talk about it as honestly as we can. Now, in lateral recumbent, rotation in the transverse plane is very available. Okay, from the top of the body, it's very available going backwards on the top side, and we'll describe this with an actual patient on the table so it's more clear. It is very available in the lower body when the top leg or the top side of the body goes forward, so rotation to the opposite side. Side bending, okay, or lateral flexion is available, but it's difficult because you have to move a large portion of the body for the patient to actually get the lumbar column or the thoracic column to actually move as far as it's capable. You have to push very hard either on the shoulder girdle or the pelvic girdle. Some people will utilize lifting of the legs off the table, but that becomes very cumbersome and very hard on the operator, and often doesn't actually give as much motion as would be suggested, because one of the concepts that we'll go over and we'll sprinkle in through all these videos is that often the motion at the end of a lever is much more dramatic than at its target, right? So say we just take my shoulder. If I lift my arm this much, the amount of motion, the degrees of motion, what you see at my hand is much greater than what is actually happening at the GH joint. So often it seems from personal observation, that when people lift the legs off the table, say they mobilize a patient and utilize the legs as long leverage to try to tip the pelvis onto the lumbar column, often the visual of the feet makes people think that the pelvis has tipped further onto the lumbars, or that the lumbars have articulated farther or move farther than they actually have. Now, it does move them, and it moves them quite effectively. It's just often, it's an exaggerated concept. So we've just talked about the coronal plane. As far as the sagittal plane is concerned, in lateral, the sagittal plane is very difficult to engage. Not impossible, but it's very difficult, and usually to be as effective as you want it to be, it actually involves a lot of patient motion. The patient has to actively move. One thing that will occur is people will use things such as legs to create lumbar extension or lumbar flexion. Now, the top leg is quite free to move because it's not in contact with the table, but the bottom leg is in contact with the table, so you get drag, you get friction. As far as extension is concerned, when that leg comes back, and we'll look at this, so we will definitely use the video camera to show this to you, but when the leg comes backwards, you get quite good, essentially coxofemoral extension, so the leg goes behind the body, but then what you have a difficulty with is actually getting good lumbar extension. It's not impossible, but it's difficult. So often you're actually better to have the patient be as active as possible so they move themselves. As far as flexion is concerned, when you bring the knees towards the chest within the lumbar column, you again get the drag off a table and you'll get soft tissue approximation. So before the lumbar column will move, you will usually get approximation of the thigh to the abdomen. So soft tissue approximation blocks you. So it's actually better, as far as leverage is concerned, to often try to move the pelvis itself to then get the lumbar column to move, or to have the patient actively go into a flexed position if you wish to create the flexed position within the vertebral column, be it lumbar or thoracic. Now, they are available, the motion in the sagittal plane is available, but again, it's difficult. We just talked about the difficulties. Now, instead of just continuing to talk about them, what we'll do is we'll show them to you with the patient on the table. So we'll look at each plane of motion in lateral, and we'll discuss pros and cons, and we'll show some of these common problems or these common things that people seem to believe are occurring, but may not be occurring as much as they believe. So we're taking a closer look at lateral recumbent or side lying here, as far as the things that are easy to do, the motions that are easy to create and more difficult to create. Okay? So 1/2 of the patient is in contact with the table. Okay, so we go back to our first series on patient positioning. The patient still has a fair amount of contact with the table, say as compared to seated, but not as much contact as compared to supine or prone. Okay, so the table is not making this patient as stable. So the way that I move this patient, the way that I position them, it all matters. Now, just so you understand, the two easiest planes to work with here, or the easiest plane rather to work with in lateral, is the transverse plane. I can create rotation of the patient without much issue. Okay, those are not the two ideal ways to do it. Just what I showed. I just want to show that it's easily available. Now, the coronal plane, with respect to the vertebral column, is not as easy to deal with. I have to make lots of body contact. I can push the patient's hip pelvis onto their lumbars to side bend the lumbar column, however much it side bends in the given patient, because it's different for each. I can create something, but it's not ideal because there's a lot of heavy lifting involved for me. I can push downwards. Now the thing here is that this creates a lot of scapulothoracic movement, but not much thoracic vertebral motion, although many people like to speak about it doing that. It just doesn't quite work out if you ever actually look at it. The upper limb is quite accessible to me here, and I can work with the upper limb essentially any plane. Sagittal plane, without much issue. Coronal plane. Transverse plane, or to better show that, transverse plane. Upper limb, quite accessible, quite easy to work on. So if a patient had a problem with his right shoulder in this case, I could deal with it quite well. I could get through the scapula and the GH joint all at the same time. Now the hip and the leg are available to me, but because they're larger, they're more cumbersome, they're harder for me to work with. But I can work in the sagittal plane, I can work in the coronal plane, at least into abduction, not so much adduction. It's much more difficult because eventually they run to their other leg of the table. I can work essentially, although this isn't the ideal position to show right there, I can work somewhat in the transverse plane. It is available, but the leg is heavy. I have to lift it off the table to do all that work. Now we're going to move on and just show you something a little bit different. We're going to have the camera in my hand just to attempt to show you a few things. Okay? So here we are with my handheld shot. Now hopefully this works out reasonably well. It may not be perfect. What we're going to look at here is the coronal plane, just so you can see this. So you can see the patient's back. So I want you to lift this hip up to your shoulder. See how far that moves, okay? Now this isn't ideal because I have a camera in my hand and it may not show up as well as we want, but I can't quite force him to go as far as he's able to. So we have an issue here. I can attempt to engage the coronal plane by pushing the patient's hip towards their lumbar or their pelvis to tip towards their ribs to create whatever side bending is available in the lumbars. But it just won't work as well as the patient doing it. So it's something to be aware of. Now the same thing, what I want you to do, I want you to go ahead and try to take your shoulder down to your hip. Okay, keep your head on the pillow. Okay, so that doesn't work all that well, patient passive. But if I go ahead and I push down, okay, I can move the scapula, and although his shirt's wrinkling, I'm not getting much motion out of the vertebrae. Shoulder's moving, but not much motion out of the vertebrae. Now what we want to show you is engagement of the sagittal plane. So we're going to attempt to show this, but hope it may not work as well as we want it. What I want you to do is bring your knees up. So get your bottom hand out of the way. Bring your knees up to your chest as high as you can. Okay, and just look at what is available there as far as motion in the lumbar column. So bring your legs down a little bit. Bring them up again. Okay, bring them down. Bring them up. Okay, now that doesn't create all that much motion in the sagittal plane. Although there is some motion, it's not as much as might be available. So hip flexion
So knees to chest may not create as much lumbar flexion as we want. Bring your legs back to kind of a normal position. What I want you to do is I want you to stick your tummy forwards as far as you can, okay? That's extension, that's lumbar extension, and we can see that. We can see his abdomen going forwards, we can see some lumbar extension. What I want you to do is go back to a normal position. Now what I want you to do is stick your tummy backwards as best you can. Stick your tummy backwards. And look at that amount of motion, okay? Go back to a normal position. Bring your knees up to your chest as far as you can. Look at what happens to the lumbar column there. Come back to a normal knee position. Stick your tummy backwards. Okay, perfect. Do that again, relax, stick your tummy backwards. There you go. So the amount of motion, although it's not all in the sagittal plane, there's more motion when the patient actively sticks his tummy backwards. Okay, so we can engage flexion better with the patient's abdomen moving actively than we can knees to chest. So there's a lot of osteopathic practitioners and other manual practitioners that will pull the patient's knees to their chest in order to create lumbar flexion. It doesn't work all that well. What needs to happen is motion of the abdomen. So the pelvis actually needs to go forwards. And there's ways to do that, and we can talk about that as far as technical applications in the future. But we need to understand that hip flexion doesn't really do all that much for lumbar flexion. And again, the lateral position is best to work on the arm, okay, the upper limb and the scapula. You can work on the hip quite well, and it's very good to work on rotation or working in the transverse plane. Some work can be done in the coronal plane, some work can be done in the sagittal plane, but it's not as good as many claim. So just to attempt to kind of further show this idea that the practitioner trying to bring the patient's knees up to their chest versus the patient moving their abdomen doesn't create differing amounts of actual motion in the lumbar column. So what I'm going to have you do is bring your hips towards me. So slide your pelvis forward. Thank you. That's it. That's good. Okay. So now what I'm going to do is I'm going to take the patient's knees to their chest, and you're going to watch their lumbar column. Okay. I'm going to try to keep his shirt tight so that we see this. Okay. So this may not show up perfectly, but we're going to attempt it. Okay. So this isn't even as far as the patient is able to bring his own knees up. Okay. So we look here. Right. We look there. We come back, you're going to see some motion in the shirt, but hopefully we get to see this reasonably well. Now what we're going to have him do, I want you to stick your tummy backwards, and if you look at the amount of motion that happens there, it's a greater amount of motion. Relax. Okay. Now there is a way around this. Okay, so we have to get into full hip flexion. We have to get into full hip flexion as far as we can go. And then what we would want to do is come around and move the pelvis. We cannot create that lumbar flexion until the hip is bottomed out. We have to bottom the hip out, create as much hip flexion as possible within reason without hurting the patient, and then we have to tip the pelvis, right? So we actually have to kind of get a hand around, lots of contact, lots of control, and create more motion. And that's just a little technical thing that I've noticed over time that we'll discuss now. And we'll discuss more things like that as we go.